Good afternoon, everyone. Thank you so much for joining us again. I'm so pleased to be back after the lunch break to introduce our keynote speaker, Mae Katt. So Mae is a primary healthcare nurse practitioner from Tamagami First Nation and lives in Thunder Bay, Ontario. Actually, I just learned just outside Thunder Bay, Ontario. She has an honors Bachelor of Science in Nursing, Master's of Education with the curriculum specialty, and an honorary Doctor of Laws from Trent University. Mae coordinates a mobile treatment team that serves remote and rural First Nations to provide opioid agonist treatment with buprenorphine naloxone and injectable buprenorphine. Mae also provides primary health care and mental health care to students in an urban-based Indigenous high school for over 20 years. We're so happy to have you here with us, Mae, and why don't you take it away? Thank you so much for being here.
Thank you, and good afternoon, everyone. I'm happy to be here. I had a look at the program, and it's timely that we're talking about opioid use in primary care. So I'm a primary healthcare nurse practitioner. I have been working in the field of mental health and substance use for about 12 or 13 years now. I got pulled out of a life in a clinic when I was asked to come and support the Northern First Nations as they were experiencing an opioid crisis. Some of our communities had anywhere from 50 to 80% of the population addicted to OxyContin at the time. So the title of my talk today is Culture as Intervention. We've been using culture, and I'll explain that, how we're using culture to help our communities get through their experiences with opioids in the early, I guess it started in around 2005 and 6, it started to get really bad. So I had to do a disclosure slide. I do get speaking fees for education from Indivior Canada. Been helping them on some policy work with buprenorphine naloxone. At one point, I'm going to mention brand name just because it fits my slides. The objectives that we have today is learning about our experience in Northern Ontario, First Nations, and then some of the substance use and the treatment we've been doing. Secondly, looking at the underlying root causes and the cultural approaches to healing. And the third one is to learn how to support First Nation clients that you may encounter in your practice. This is the geography of Northern Ontario. We have 2/3 of the land mass in Ontario. Again, if you look at the map of Canada, we're sort of at the center of the country. The outline for my presentation, all those little colorful dots are communities that I work. 49 First Nations known as the territory of Anishinaabe Nation. They're all color-coded because they're politically organized in tribal councils. And most of those are fly-in. Some around the lower part or the center part are road access communities. I'm going to talk to you about the First Nations mental wellness framework, some of the cultural ways to wellness, trauma and history, which again are the root causes for what we're seeing presently in our communities with opioid as well as other substances. Our current treatment model, I'm going to explain that to you. Some of the wellness outcomes, we use wellness instead of recovery. It translates different in our language, so wellness makes more sense to us. And then I'm going to end with something on grief counseling. I was explaining to the moderator that, when you look at the mortality rates for Ontario, right now Thunder Bay has the highest mortality rate per 100,000 population at about 64.3. But every northern urban hub across the north has higher than the provincial average. The provincial average is 13.1. Sault Ste. Marie is 44.4, North Bay is 41. So again, we know that there are a lot of people experiencing loss from deaths from contaminated substances. So we do have a framework. Again, everybody says, well, what model of treatment do you have? Again, with my mobile treatment team, I have registered nurses and counselors that I take into communities with me. And we do inductions. The first couple of years, we inducted over 500 people onto the brand name buprenorphine naloxone. So we use the mental wellness continuum framework. And the value of this is that it's indigenous. It's something that communities can relate to. When you look at the wheel itself, it's holistic. Again, every human being is holistic. We have physical, mental, emotional, spiritual parts of our being. When you look at the center of this is the goal for treatment, is to help our clients reach a state of balance, dealing with some of the issues that they're bringing to you as a provider. We all focus on hope, meaning, belonging, and purpose. And that hope, meaning, belonging, and purpose is really centered to what we do with our clients to help them change their lives if that's what they're coming to you for. I have a quote here. First Nations interests, knowledges, and practice have not been afforded a key opportunity for authoritative recognition within the health sciences. Thus, the evaluation of locally emergent, culturally grounded treatment alternatives retains not only the possibility for achieving greater treatment effectiveness, but also the prospect for promoting social justice relative to the potential legitimization of a wider diversity of health interventions. I will explain that as I go along and what it means to the work that we've been doing in Northern Ontario. And just to remember that hope, meaning, belonging, and purpose is relevant for all people. It's not just for Indigenous people. So the principles that we use in our treatment model is really culture as foundation. Spirituality in the past was from the land, the respect for life, ceremony, food, language. We talk about Mother Earth. We talk about, Grandmother Moon. And our spirituality is, again, the elements that we relate to historically. Family is centered to our well-being, kinship, bonding, stories, legends, heritage. Our ancestors are all part of who we are, and how we understand of who we are comes from our traditional and our family practices. Every community is different. Every community has their own history, their own trauma, and their own wellness approaches. Okay, my slides are stuck. Hang on here. So cultural ways to wellness. We have documents. There's access to literature through the Thunderbird Partnerships Foundation.org. Carol Hopkins, if you've ever met Carol Hopkins, she does a lot of speaking nationally as well. And she has been working on substance abuse work and mental health in our communities for a number of years. These publications are available on the website. We talk about connection. Connection is healing. Our family, our children, our waters. Again, you hear a lot about contaminated waters in our communities, and it was never like that. We always had sort of the clean sources of water. Contamination, again, has come from industry mostly, and we're trying to rectify that. Community is healing. We do have our ceremonies. We do have our young people learning about our ceremonies, our heritage, our stories, our legends. Again, what Photographs bring, or what snapshots bring, is really a record of our being, and that we have occupied these lands for centuries. Our economy was based on land-based survival, and our medicines were land-based. This picture just shows that a young couple have lived on the land for many, many decades until they grew old and are still practicing their traditional ways. We don't have picket fences. Some of these places that we lived was, this is an old lumber camp. Again, part of your land is you just make toys out of what you see, and you don't question that. Some people would say that this is a sign of poverty. To the child, it's a sign of delight. You get to play until you get dirty. Again, many generations of a family will reside in the same location, same land, same pursuits, depend on each other. The men do the work, the women do the work, and as well as the children have the chores. So again, everyone had their job. You actually built your sense of heritage, your self-identity, your language is all created from the land. Our dogs were not pets. I had a discussion with that this morning with someone. These are work dogs. Again, very different. They did the work when we had to be on the land. So where does addiction come from? This is a pretty graphic piece of artwork by Kent Monkman. This is called Scoop. But it was our reality. There was a time where, because of unkind policies in our country, residential schools, 60 Scoop, they took our children. They took them away. They taught them a different religion. They couldn't speak their language. And again, these were the wounds that were passed on intergenerationally to what you see now in the clients that come to see you, if you're a provider. But these wounds that cause pain, the loss of loved ones, the physical, emotional, the sexual abuse, and then neglect, they're all a reality of our community members. The trauma and the soul wounds are the roots of what we see today. When you're listening to the client talk about their family, their heritage, where they grew up, what hurt them, and what they're trying to overcome, will have a lot of the roots in their childhood. So talking about intergenerational trauma, we do talk about it. We talk about, we try to understand what happened so that we can move forward. And you talk about it around a campfire. It's counseling one-on-one doesn't go over all that well sometimes. As I work in a high school, I've been a nurse practitioner in a high school and an urban high school for 23 years. And talk therapy is, some of the students will relate to it. Most of them will talk when you take them out around a campfire. So we've created some evidence. In Canada, we know that if you haven't published it, you didn't do it. So we worked really hard in the early part of our program and treatment that we wanted to set up community opioid agonist programs. So again, we have community-based Suboxone. Again, I said I was going to use the brand name because that's all that was available. Suboxone came to Canada in 2007, and we started using it in 2011. And we did that with the approval of our leadership. Our chiefs and councils wanted to bring treatment to their communities. And we set up a network of over 25 community programs in the North. Over 3,000 clients have had the treatment. Our initial treatment goal was tapered to discontinuation. That doesn't always work because of the trauma and the lack of aftercare programs in our communities. We've realized that, we're in an environment where we've had a suicide crisis since the mid 90s. And during that time, we've had over 600 youth suicides and many overdoses recently. So grief counseling is really key to the work that I do in the communities. And we always do the work in a strength-based approach. Again, looking at traditional land-based program, how do you strengthen the ties with culture and language? How do you reconnect individuals to their families, their histories, and their communities? And when I look at the pandemic and our young people being in their communities, the communities looked after the young people very well during the pandemic. And you could see that when the students came back to their urban high school after the pandemic, and they came back with many strengths from being involved in their community and helping manage the infections. Again, we had lots of COVID infections, but not a lot of deaths. I think in the area of Toluca, we only had 13 deaths during the pandemic. So a lot of care was given. We don't have great facilities. We didn't have a lot of health providers, but we were able to manage. So we did create this evidence, practice-based evidence. I published an article with Benedict Fisher in 2012, Chief Keynote in 2015, of obstetrician Nana Juma in 2016, and Saul Mamakwa in 2018. He's now a member of the provincial parliament. We used Suboxone again because it was easy to administer. It was transportable, and we don't have pharmacies in these northern communities, so we couldn't use any other substance. We're now starting to roll out the injectable form of buprenorphine, and that's happening in a number of programs. I'm going to tell you a little bit about how you can make an impact in communities if you're doing the work with the communities involved. So there was a pre and a post study done in one of the communities, northern remote communities, and it talked about drug-related medical evacuations. Again, we have to send air ambulances into the north. So the assaults, the suicide attempts, overdoses, sexual assaults believed to be related to drugs and addiction fell by 30%. The needle exchange dispensing decreased more than 50%. The children and the elderly were being brought in for medical care at earlier stages of illness, whereas when there was a lot of drug use in the community, these kids and elders were being brought in at later stage of illness. The attendance in community events increased. The sales at the local store increased by 20%, and the police criminal charges decreased by 61%. There was high retention. The Mamakwa article actually looked at retention at 6, 12, and 18 months, and that was 84%, 78%, and 72%. So what we learned from that study was that if you did treatment locally, then where the people live, then you actually have a higher retention rate. 6 communities had a dramatic decline in suicides. And then the obstetrician did 2 studies actually and showed that the treatment, buprenorphine naloxone, was actually safe in pregnancy. There's a lower rate of neonatal opioid withdrawal syndrome, and that was related to the low dose of treatment. If you used under 8 milligrams of Suboxone, you didn't get the neonatal abstinence syndrome with the babies. Nursing stations became more of a primary healthcare center than a trauma center, as less drug-related violence and its medical complications. Seasonal influenza immunization raised dramatically. It increased to 350%. School attendance increased by 33%. And this is a really important stat. The child protection cases fell by 58%. During the peak of the drug use in our communities, a number of children were put into care. A number of them went to other communities. So we focused on culture and land-based activity. It focuses on healthy living with the children and the youth, being part of that model of care, positive parenting, and respect for all ages. Again, that's essential for the well-being. We have Jordan's Principle programs in our communities, again, focused on family care. And we have the family well-being that's provincially funded. Jordan's Principle is federally funded. The focus that many of these aftercare programs did was looking at the intergeneration and historical trauma. People were exhibiting anxiety, and the anxiety seemed to be more related to the post-traumatic stress disorder versus the generalized anxiety disorder that we treat in primary care. So I'm going to talk to you now about, I did mention about the high rates of mortality. And we have in our communities a lot of discussions around providing the kind of grief counseling that worked for us when we were historically on the land and didn't have the models that we see now. So the 4 stages of a traditional grief model was actually a teaching that we got from Dr. Ed Connors. And if you know Dr. Ed, he's a pipe carrier. He's a traditional teachings. He carries the traditional teachings in the pipe. He's also a psychologist. So when Ed talked to us, when the suicides were happening in the early 90s, we wanted to know how we could support families and, at the time, parents of those who had completed suicide. So the 4-step model really looks at how do you help people get through that first stage of shock and denial. And again, it was supporting them. Our support for individuals who've lost someone is not that verbal. You sit with them, you make sure they have food, that they're sleeping, and that they're safe. So it takes time to get through this grief model. It's not a 1-hour session. Come on in and we'll see you again next week. So the nonverbal method of this grief counseling is just being there. And if you can just be there, it seems to help people come to a point where they can actually talk about what happened to them. The second step is anger. And if you have someone who's, voicing the anger, you just have to let them voice that. I mean, they need to get through that stage of anger. One of the sub-steps that Dr. Ed talked to us about is how we had to forgive ourselves. And when it comes to parents, and this happens with the overdoses as well, they feel like they should have been able to do something. They could have stopped this. And one of the things that Dr. Ed talked about is how we have to forgive ourselves, that the grief will be harder and it'll be prolonged if you don't forgive yourself. You eventually get into a stage of acceptance that you can accept not the fact that it happened, but you can accept that this is now part of your life, and getting through that. Step 4 is reconciliation, and it could take a long time. Again, reconciliation is that greater forgiveness. And if you get to that point of reconciliation, it just shows that healing has actually taken place, and people can then become functional. They can start going back to work again. They can start going out to see, to the store. In our communities, again, we have a lot of people who go out to the land and they go fishing, they go set their nets, they do the things that that bring them the kind of healing that they want. Again, about grief and loss, unless you've been, been there, it's really hard to do as a counselor, as a primary care provider. This quote is really about, I sat with my anger long enough until she told me her name was grief. And we see that. We see people being very angry. And when you can get them to acknowledging what's hurting them, then you can talk about grief. You can talk about how you move on. Those who think there is a time limit when grieving have never lost the peace of their heart. I think about the survivors of suicide and overdose. And, I have colleagues who've lost their own children to overdose. And it's every day they carry that pain, and they want to go on, right? They need to go on for the rest of their family. So this is my last slide, and it talks about mental health should be a priority. What we're talking about is pain, emotional, psychological, and spiritual pain. That pain is transmitted from one generation to the next. The work that we do in our communities is all about our young people, bringing them to a time in their lives where they can feel safe, that they can enjoy all the things that children should enjoy. People need to start talking to communities who are generally developing all kinds of ways to help their youth and their children. I guess I don't have a goodbye slide here. So just to summarize, what we've been doing in Northern Ontario has been replicated across the country and in many other Indigenous communities. In the beginning, we were asked to travel to New Brunswick. We've gone to Alberta. We've gone to Manitoba to talk to communities on being able to set up their own programs that fits with their culture. Again, not every, as I said, every community is different. All their strengths are different and their history is different. What we know about Canada is that government policies have been very unkind to Indigenous people. That, the residential schools was one harm that again, how many generations, I guess, before we can actually overcome some of those. I don't see that government policies, again, don't have the greatest impact of government policies is to let the communities do what they need to do. If there were supportive policies to set up the kind of programs that they wanted to do, then I think we would actually see the communities making more headway a lot quicker than they are, and with less dependence on opiate agonist replacement and other medical care. So I'm going to end there. I think if you have any questions, I'll be able to answer those questions for you.
Thank you so much, Mae. That was wonderful. And we are a bit ahead of schedule, but I thought I'd start with some questions myself because your talk really stimulated my curiosity around a number of things. And particularly just sort of reflecting on this last quote from your last slide around mental health should be a priority stirred something in me. I really love this quote. I've been thinking about it a lot lately around like how we could revitalize the mental health in primary care system in Ontario. I'm just wondering, after decades of experience and certainly working at the front lines, do you have any thoughts about what this could look like moving forward if we could revitalize the system, understanding that, short visits within this fee-for-service model really isn't working for most folks? So I'm just curious if you have any thoughts on that part first and foremost.
I think from the experience I've had in the with the adolescents, we do have a model of care that's pretty much wraparound care that includes a clinical team. We do have a psychiatrist on our team who's available for dealing with some of the assessment and treatment of early psychosis. And we know that if we have early psychosis and if you can address it right away, you can actually prevent it from reoccurring. So we have clinicians who work in our high school. I've been there, as I said, 23 years. And dealing with anxiety is probably one of our biggest challenges in September. And one of the reasons for that is these young people are leaving their home communities. They're coming to an urban environment into strangers, and they lose their safety. They've lost their sense of safety, and their anxiety turns into panic. And so part of that is we have elders in our school as well. And sometimes the elders are the best modality of treatment for them. Yes, we can start medication. Medication is not always indicated, but we know that we can provide a sense of safety in a familiar surrounding for them. So the elders do that. They also feed them, right? I mean, that's kind of what elders do, is they provide that home environment for them. When we look at mental health episodic care, because not every, they have to go to school, right? So they have to be in class, but again, there's always someone who's taking care of them. Either it's their counselor or their teacher. We only have 150 students, around 150 students. So again, it's a focused environment, and a lot of recreation takes place as well. And then cultural programmings. One of the programs that we use, our high school has also had a high rate of opioid addiction. 43% of our student body was addicted to OxyContin. So we treated them very much like the community-based programs. We brought the treatment program right into the high school, and we had them on short-term buprenorphine naloxone. And after about 9 months, they were able to taper off because they hadn't been using the opioids for very long. So how we did that was really around keeping them busy, sports, cultural programming. They learned how to make regalia. Again, there were things that they were interested in. One program that we had was teaching them about dog teams. So they had to choose their own dog, and the dog was kind of like their personality. They had to groom that dog. They had to care for that dog. They had to race that dog. And so it was all about the emotional part of the bonding that, and caring for someone, and then trusting, because a lot of their experience as young children was that they had fear of dogs, right? Because they weren't using dogs. That's why I threw the slide in of the dog, is that is part of the emotional support that the students had that helped them get better. Long answer to your question.
No, that's so great. Thank you so much. I'm just noticing a comment from Maggie saying that in Durham region, it's an up to 18 months wait for a psych assessment, which is, a real challenge for a lot of communities in Ontario at this time. So it's hard for that sort of interdisciplinary care. And I guess just reflecting back on what you were saying, what I'm hearing is really addressing like the biopsychosocial, spiritual components of a being, of a person, in looking at treatment modalities and just treatment in general. I also was curious about induction protocols that you're using with buprenorphine in northern communities. Are you using, the standard or traditional induction protocols? I've heard about group-based or group inductions as well. Can you comment on any of that?
Yeah. So when I first started traveling up north, in the first year, I made over 100 trips up north. And we inducted 20 people at a time. So we would show up with the Suboxone in a little, as a nurse, I had to have a narcotic behind 2 padlocks. And the only way to carry something on a little plane was to put it in a toolbox and put padlocks on those. So we took them up north, and we had the community-based workers prepare the clients to say, you can't use drugs for 12 hours before you come to the program. So we would have 20 people in withdrawal. And then at that point, you could only do 8 milligrams was top dose. So we used ancillary medications like clonidine, Gravol, ibuprofen, and trazodone to help them through their withdrawal. And then when the formulary changed to have 12 milligrams as first day 1 dose, that helped a lot better. Although we could do a PRN on day 1, the 12 milligrams seemed to help. And then we could give them a 4 milligram take home dose PRN if we had to. Within 24 hours, they were so much better, right? We left after 3 days. So we would arrive in a plane, we'd bring in the Suboxone, we'd do all the inductions, we'd do the histories, physicals, labs, and then we would leave, the clinical team would leave, and we always left like a nurse behind for sometimes, a couple of weeks to make sure that everybody's dose was adequate, and then we'd leave the community. We'd go back many times to do 20 people at a time. One community, I did the first 100 patients within 8 months. And then they had people on maintenance doses, and then the communities took care of them. They hired unregulated care providers. It was expensive to hire clinicians all the time. And that's how they were able to provide the treatment. So the clients would come to the program, they'd get their daily dose, they'd sign for it, and then they'd go to work and come back again the next day. So it worked out for them.
That's so great. Thank you. And I'm hearing also just a really critical, the element of community. And, these group-based inductions aren't something that we're currently doing in Toronto or in urban centers, but I'm just curious whether you have thoughts about moving in that direction, understanding that community seems to be a really critical element to healing.
So since we started these opioid agonist treatment programs, we don't do group intakes anymore because the volume isn't there. I just came from a community last week, and I started two people on oral buprenorphine naloxone. And again, it was a nurse who actually did the induction, and you do it over a couple hours, and then they have to be stable on oral medication until you can actually do I think we're doing the 2 injections on Saturday. That's tomorrow. So again, now their choices was they wanted to do the injectable monthly formulation of the medication.
Great, thank you. Since there's no other questions coming in, I'll keep it going if that's okay. Actually, there is a comment. May your work is legendary and powerful. I hope there are many others under your mentorship to glean from your wisdom and perspective. I agree. Thank you for that, Carla. Mae, what kind of advice can you offer urban tertiary care hospitals and clinicians who are caring for Indigenous patients, either admitted or who are presenting to our emergency rooms?
Yeah, I mean, you're kind of alluding to the racism that's being felt by people who show up and emerge. And again, if they're in withdrawal, they get sent to detox, right? And that's a good place for them because it's equipped to handle people who are in detox, who are detoxifying. right now what we're seeing, this is the era of fentanyl and methamphetamine and benzodiazepines, right? So there's not just one substance that people are withdrawing from. And so detox is a good place. And right now they can start opiate agonist treatment in those locations, or they can call a provider who will take them right away so that they can go down and start on OAT. But I find in hospitals, they seem to have disowned this population, and again, it's the stigma. It's just not recognizing, I think, some of the deeper issues that the population has. And I'm sure that was said this morning on your lived experience panel, that they don't really want to know what your path has been. They just want to get you out of there quickly. I think if we were able to have emerged docs know who to refer to, even in the community, and say, hey, May, I have this patient who used to be on your program, has relapsed. Can you take that person back and have that kind of call? And then you could get them into we have a RAM clinic. RAM is an excellent model of care in Ontario. We can quickly get people into medication if that's what people want. And again, sometimes it's temporary. I mean, if you could just give them enough until they can get the money to buy what they want, then at least you're saving a life, right? So emerge with Indigenous population. We've had horrible experiences with being, walked off the property and going to the next property and hanging themselves. That actually happened here, and it was a policy. It was a policy of that hospital, instead of being more open to people who use drugs and say, when they do come, let's do something better, right? And it's that challenge of, we're all people who have chosen a health profession. So let's use that training and education to help people no matter what they look like, right? And again, it's raising the bar on what our expectations are for us, ourselves as professionals, and ensuring that we take that attitude to every patient that we see. And it's hard. It's hard to do that when you run off your feet and you have people waiting and you have people yelling at you, and that there's 50 people in a waiting room, but you can share that. My mobile treatment team was about sharing the workload, right? So we would go in 3 or 4 people, but we would work with 3 or 4 people in the community as well. So when you share a workload like that, it's not just one person, right, who has to be there consistently or continuously. The counselor, again, was so key to the team work that we were able to do. Being Indigenous, I think, helped the fact that, we see people at their worst when they're in withdrawal, and they have shame and they have physical symptoms, and they're going through a really bad time, but they've made a decision to change their life, and that has to be supported. And so we were able to do that, and the teamwork worked for us. And it worked for many of these communities. We have 25 programs now up north. And the complication right now is we're seeing more methamphetamine. We're seeing other drugs coming into our community. And we know that as soon as you mix methamphetamine with alcohol, you start to see the violence. So we're getting to a point now that we're concerned, very concerned about new substances. We have a model of treatment that is, provide treatment, do security, try and prevent the next generation from becoming addicted, and deal with the root causes. So that's the strategy we had 12 years ago to deal with the addictions in our communities. We've done a lot, but I think we can't erase history. We can't erase the history that Indigenous people have gone through. And unfortunately, providers who are in emerge departments don't know our history. Again, they come from another culture, and new Canadians don't know our history. And there's assumptions made about who we are and what our worth is in this country, unfortunately.
Thank you so much for sharing that really important insight. And I think I also just want to put a plug in for what I'm seeing right now in our academic institutions in Toronto. I work at Toronto Western at UHN, University Health Network, and we have an Indigenous patient care navigator working in our emergency department there, which is really, really helpful. And also at CAMH, the Shikabi-Makwa program, we have an Indigenous care navigator as well. Someone actually came yesterday to see a patient I was caring for in the ED, and was able to take the patient out of a secure area in the emerge to be able to do smudging on the property and then come back into the emerge. And it really seemed to calm and settle the patient in a way that, you know, the medications just weren't able to do. So it was really such a gift to be able to play witness to that. And I really hope to see more of those traditional practices integrated into the care that we provide. And I think having these patient care navigators and maybe putting forth to the government the importance of funding that kind of programming is really crucial to be able to sort of bridge the gap. Because you're right, like a lot of care providers are just not equipped or have the capacity for or have the knowledge of the history and being able to provide the care that these patients really need. So thank you for that insight.
Mm-hmm.
Yeah. Anything, yeah, you want to say something on that?
Yes, so somebody talked about the high school kids. So in 2011, we inducted our first cohort of high school students who were addicted to the OxyContin. And we were able, the youngest was 15. And again, this medication, it says, you know, it's only for anybody 18 and over. But as a clinician, you have to weigh the pros and cons, right? And so we knew that this 15-year-old was not going to stay alive until he reached 18. So we did provide the sublingual buprenorphine to him, and he did well. He was a hockey player as well, so we had to accommodate his hockey practice and games. And so our youngest was 18. The average age was 17. They had been using Oxy for about anywhere from 9 months to 2 years. There's an article that we have. I can't remember all the details of it, but again, it was written with Mel Kahan and Anita Sirivasta and myself. And so we did a retrospective study on the students who went through the program, and adolescents did very well with the OAT. But you do the kind of care, again, they weren't as traumatized. That was the other element that made it easier. Their trauma was related maybe more to their parents using drugs and what they saw, so what they witnessed, not that they totally experienced. And so high school students, it was a successful program. Some of them relapsed again when they went back to their home community because the drugs were there. We treated 63 adolescents during that 5-year period, but our school, after 5 years, had no more opioid addiction in the program. And it's not because we did a really good job in the school, it's because we took the treatment program up to their home communities. Of all the students, only one actually got addicted in the city. They were all got their opioid addiction while in their home communities. But once we started the treatment in their home communities, our school didn't have them coming to the school with the opioid addiction.
Any other comments or questions for Mae?
So we are using Sublocade now. That's the I'm not supposed to talk brand names, sorry about that. The buprenorphine injectable medication. So we're starting to transition those who've been on oral for a long time and they want to use Sublocade as an exit strategy. So we're starting to do that with the existing program. What we like about Sublocade, of course, the injectable, is that it's protective against fentanyl. The product monograph does say that it will protect you from respiratory depression if you have the Sublocade. So in the city here, we have physicians who are doing the Sublocade, and sometimes it's when they do experience contact with the fentanyl, they are not dying. So I think that's pretty good evidence of how we should actually do these new formulations. And it may not be that cost effective for a provider who's billing, and maybe we need to look at compensation differently in Ontario. Nurse practitioners, of course, were not compensated in any way publicly. We don't have publicly funded compensation for independent practice. And I think sometimes we need to look at the way the compensation actually encourages different formulations of treatment. Because right now, with all the overdoses, Sublocade is pretty important to the client.
Is there a lot of interest, Mae, from the communities for buprenorphine extended release or injectable form?
Yeah, again, it's for two reasons. One is it's easier for employment. They don't have to go and get daily doses. They actually don't mind, an abdominal injection and a little lump in their abdomen. And they just don't want withdrawal. They have, their worst experience is withdrawal, and they don't want any of that. So when you taper off oral, they get withdrawal. And so with the Sublocade, it's a much smoother exit for them. But yeah, they're interested. I'm going to start another one this week, actually. So, and it's paid for. It's for Indigenous people. Sublocade is covered under non-insured health benefits.
Thank you so much. Any final comments or questions for Mae? Oh, here we go. Do people need to take Sublocade indefinitely, or can they come off after a time?
So the injectable dosage is when you're starting, you do 300 milligram. Your second injection is also 300, and that's to get the medication into the therapeutic trough. And then you switch to a 100 milligram. They still stay in the trough, and they can actually keep coming back for monthly injections. If they want to stop, they can just stop coming back for that monthly injection. So the medication will actually stay in the system 6 or 7 months and slowly dissipate, which means if you are doing drug testing, you will find it in your urine drug screen. So whatever you're doing urine drug screens for, it'll be positive, and you have to tell them that you're on the injectable long-acting. You're not using, illicit formulations. So no, we have people, 3 or 4 injections, and then they stop coming, and then they're done their treatment.
That's wonderful. Sounds like some really positive results, and there's a lot of receptivity from the communities and community leaders too. Is that right?
Our community leaders want people off oral Suboxone, oral formulation. And I think it's because they have to pay for that, right? These are not funded programs. These are, Again, in a city, you will get services that are funded, but the chiefs and councils are usually paying for these themselves, so the hire the workers. And what they want to do is just be a little more cost effective.
Okay. I think, oh, we have one more. So people on Sublocade should not feel withdrawal after 3 injections.
Yeah, so Sublocade starts working pretty much right away. You can do an oral top-up if they're still feeling after their first injection of 300. But after a while, like, they're not feeling withdrawal at all because the medication is in their system. But once they stop, so if you're if you're getting this every 28 to 35 days and you're not coming back for that other injection, it's so smooth that they don't feel the withdrawal. So one of the symptoms that I think people dislike the most is the sleeplessness, right, and the restlessness. So they don't seem to get the kinds of withdrawals from the injectable that they would from some of the oral opioids that they've been ingesting. The one who knows, Dr. Sharon Cerrone has been doing Sublocade in a community, and many of them are using it as an exit strategy. It was with the author that I mentioned, Keynote, and they're doing a study on that. Again, part of working in an Indigenous community is you go to the leadership and you ask for permission to do the documentation and the data that's required to publish. So our communities are quite open to publishing some of the evidence that they've created through these programs.
That's so helpful so that we can all learn together and continue to move forward in supporting some of these folks in really tough spots. Yeah, I'm really glad to hear that. I also actually, just on that note, before we part, you showed a lot of data around sort of implementation of buprenorphine and then significant improvements in terms of community wellness, including like reduction in crime and bringing youth or elders to care earlier. I might have missed it, but what kind of timeline post implementation was that you guys looked at?
So that was in the Keynote article, 2015. I can't remember. I mean, we do have the articles available for anybody who wants them. I think I put my email address up there. Again, we can send those out, and it's good evidence to show that whatever you feel is going to work in your community, and you try it and make your adjustments. That usually your intuition on your community and how they would accept certain programming usually works for that population.
That's great. Another plug to study and publish as much as we can so that we can get the word out. Knowledge is power. Disseminating the knowledge is so important. Okay, so I think we're just at time. Thank you so much again, Mae, for such a wonderful talk. And again, so grateful to have you with us. And I think we'll just end a minute early. But yeah, we really, really appreciate your knowledge, expertise, leadership in this area. And we are truly learning so much from you. And as one of the comments mentioned, I hope there's lots of mentorship happening so that when you are moving into retirement phase, that you're passing the torch to some really wonderful clinicians. I'm sure you are. And it sounds like convocation is happening up at NOSM today. So that's a wonderful sort of marker of that as well.
And thank you for inviting me. I look forward to to trying to find somebody. Nurse practitioners, there are a handful who want to do this kind of work. Again, we're only 5,000 strong in Ontario, so if you have nurses who want to further their career, it's a great role. So I can't say enough about, you know, the things that we can do in our scope of practice as nurse practitioners. Thank you. And have a great rest of the afternoon.
Thank you, Mae.
Okay, bye now.
Bye.